We have this surgical strike vision of how to fix the problem that has nothing to do with the culture and the reality that that person inhabits for the entirety of their lives, other than that 10 minutes that we spend with the patient. For a lot of our patients, when they talk to me about these folk remedies, they don't simply say, this is uña de gato, or this is a particular folk remedy, and I know it works. It's never that way. It's, this was founded a very long time ago, and it came from a special place that we know has great power. And I know that my cousin's cousin was able to take this, and they had been terribly ill, and it worked for him. And then he met a number of people for whom it also worked. So take this, use it very carefully. Maybe don't even tell your doctor about it, because it's one of those things that doctors don't believe in. And by the time that the patient gets the folk remedy, it's been so invested with mythology, power, the sense of magic. How could it not possibly work? Culture plays an extraordinary part in this. It's an inseparable part of how we experience the world, how we taste what's around us, smell what's around us. All these things are inextricably tied to experiences that we have throughout our youth, the mythology of our parents. So to the extent that we don't understand a patient's culture, then we fall far, far short of ever being able to engage them completely as a human being. Part of what's evolved is that we've gone from a period of time when the only two guaranteed or almost guaranteed moments when a physician would interface with you and your family was either at the time of birth or the time that someone died. And in between, it was a big blank space where maybe somebody might engage a physician, but typically that was driven by the presence of a disease. We now know that the best way to manage people, the best way to try to preempt the bad consequences of disease, is by forming a long-term relationship where the physician can help empower good behaviors, provide information that is relevant to target activities by the patient and their family, and help in collaboration develop a realistic set of goals for what happens throughout that lifelong journey. And that's a very, very different model of healthcare than what people may be familiar with. We see the patient for 10 minutes. In general, we spend a certain amount of time fumbling with the computer or dealing with the medical record or dealing with things that have nothing to do with the patient. And then our conversation tends to be very, very directed. You have high blood pressure. This is a pill that might be able to help with your high blood pressure. By the way, whatever you're eating that's high in salt, cut out that high in salt thing and don't eat fat. And you need to watch out for these things. The other problem is that you're dealing with delivering what is probably an essential message, but in the worst and least effective way possible. We don't ask the patient about what their thoughts are. What your beliefs are? Where do you think high blood pressure comes from? What have you been told? Who around you supports you when you make decisions like buying a medicine, deciding to actually take it once you've bought it, being able to change your diet because they may not be cooking for themselves. Someone may be cooking for the entire family. And one of the things that always is of value to me is when I see a patient, and typically I'll see them with their family members. I'll see the father, the mother, the grandmother, and the children who may be all crowded into the examination room. And I'll be honest, the harder, more skeptical audience to deal with is going to be the mother and the grandmother, because in general, the patient will ask about their medicines, about the expectations for that encounter, and then it's the mother and the grandmother that will ask the very hard questions. Doctor, is he cured? Doctor, I heard about this medicine that was, a friend of mine's been taking it. She's doing incredibly well. What do you think? Why shouldn't he take it? So the presumption is that we're keeping patients away from a very important cultural asset in moving forward in their care. And why shouldn't they do it? And when you have your mother in the room and the grandmother in the room, and in fact, oftentimes I'll have young male patients and they're cowering as their mother and grandmother is speaking, and you can see who really is making the decisions for the family. It's fascinating to me, and part of what we have to do, part of the obligation upon me, is to engage everyone with a sense of respect and understand that the narrative of that person begins with the family around him or her. I find that I can be more successful in patients with diabetes if they're not in clinic alone, because it becomes easier to ignore things that are uncomfortable. Having to prick your finger regularly, or inject insulin, or adjust the insulin doses, because it's very rigorous, it's time consuming, it may be inconvenient. But if the whole family is there, and if I can successfully convey a sense that they're all invested in this care, that they all benefit by this person's blood sugars being controlled and his diet being there, then I know that the daughter that's there with him is going to remind him to get those finger sticks done, and that his mother is going to ask them, what are the sugar readings? And by the way, we're going to change the kind of foods that we eat because it's going to help my son. So in a lot of ways, we often look at the mindset of one patient speaking with one physician, but I feel like we can often be more successful in diseases like diabetes, like obesity, if the family is there. Because if we can engage with those people who create the day-to-day narrative of that patient, we can make a long-term impact upon how they do. American medicine in general does a very poor job of reconciling a skeptical mindset with the mindset of people who are actively seeking and engaging themselves in faith and hope. And I think the way that we can best serve patients is to understand the nature of their hope, the nature of their faith, the fe, what really drives them from day to day, as opposed to having that skepticism, that scientific idea that unless it's proven, I'm unenthusiastic. And that's something that American medicine doesn't do a very good job of doing, is bridging these two mindsets. Although ultimately, it's about achieving the same thing. All of us want effective therapies. All of us want to give our patient hope. It's just from a scientific point of view, until you've proven definitively that something works, we're always a little bit dour and skeptical about maybe it won't work. We used not to want to offend authority. We don't want people to throw us out of their families or refuse to care for us or discount our concerns in the future. So one of the issues that I've seen with Hispanic families has been this desire to not only not question authority, but to want to please people as well. And how can you please them if you're questioning their edicts and their pronouncements and their medications? So I think redefining that relationship so that it becomes more like one with a family member, where I would say the disproportionality of how people view themselves can be equalized. So we're simply human being to human being having a conversation would be a much better model for speaking to patients and their families.